Hey, I think let's get started. And then as people come, I'll add them on. So thank you all of you for joining again this week. This is our second Talk in the Health series. It's really nice to see all of you here. We've had some really great feedback from the last session. So I think the interest is definitely there. So we're excited to keep doing these. I just wanted to go over it again in terms of the plan. So as I mentioned before, this is a women's health series. We're particularly talking about the hormonal journey. So we're going to cover everything from, today's the last session on perimenopause and menopause. We're then going to go into screening. So that's all cervical cancer, breast cancer, and bowel cancer screening. And then we're going to break for Ramadan. And once we come back, we'll talk about mental health, and then we'll go on and continue with the hormonal journey. We've had some feedback already about the talks people want, particularly to do with obesity, and there was other topics that we've had. We are taking that on board, and we will plan that for our next series. But we're trying to do it so that we kind of can hit as many areas as possible. So we are taking all of those on board. Okay, so even if you don't see them on there yet, they're coming. If there are still requests, please keep them coming. Okay, so it's yeah, without further ado, let me introduce you to my very dear friend and colleague, Rashida Shamshuddin. We created the idea of this health series together. And yeah, and oh, the other thing is also, if you have any questions at all, if you're not comfortable, you can actually type them in just to me or to Rashida, and then I can always read them at the end. So it can be anonymous. So please feel free to ask any questions. If you do end up having questions after this, you can send it on the email that you got the link. If you haven't, at the end, I'll put it in the chat box now too, so you can send in your questions there. Okay. All right. Over to you, Rashida.
Okay, thank you, Fatima. Welcome, everybody. I'm just going to share my screen. Okay. Can everyone see? Everyone's good? Fatima, everyone?
Yes. Yes.
Okay,
Yeah, sure.
perfect. Okay, so yeah, so I'm a family doctor. I work in Bolton, and I have a special interest in women's health. Majority of my patients are women, and actually around 50 to 60% of my patient population is in the perimenopause, menopause phase. So I see this quite a lot. I treat it quite a lot. And it's a journey that women go through, that we're all going to go through. So I'm excited to share some of the treatment for perimenopause and menopause with you all today. Just a quick summary. So what we discussed last week, menopause is a natural change. It's a change that every one of us is going to experience as we get older. And menopause is defined as a point where a woman has not had a period for 12 months. Perimenopause is the time before this. Can everyone just mute their microphone? Okay, there we go. So perimenopause is the time before menopause where your hormones start to fluctuate and you start getting these symptoms. And what's key about menopause and perimenopause is that every woman will experience menopause differently. So what is a symptom for you may not be a symptom for someone else. What is a mild symptom for you may be a severe symptom for someone else. And so it's a very unique experience that women go through. And the symptoms, as we talked about in detail last week, so you've got your vasomotor symptoms, such as your hot flashes, the genitourinary symptoms, such as your vaginal dryness, painful intercourse, increased urinary tract infections, your mental health symptoms, so things like anxiety and depression, and other symptoms, so weight gain, cardiovascular disease, abdominal symptoms, et cetera, et cetera. There we go. So when should you start seeking care for menopause? So It could be at any point where you feel that your body is changing. So if you start to notice a change in your cycle, so if you're somebody who has regular periods every month, and then you start noticing that you're getting spotting in between, or you're starting to notice that your periods are getting heavier. So any kind of changes like that, definitely go see your doctor. Any mood changes. So you find yourself suddenly being more angry or more short with people, or you're starting to feel more depressed and sad, go talk to your doctor. Changes in sexual function, increase in urinary symptoms. So for example, if you're someone who never got a urinary tract infection, now is getting them frequently, that is also a sign that, you know, you could be going through this change. And weight gain as well. So weight gain is one of the most common complaints that I see in my practice, is when women hit in their 40s, mid 40s, and they say, you know what, I've gained this weight and whatever I do, I can't get rid of it. Definitely go and see your doctor. So when you come in to see us, we are going to take your history, we're going to listen to your symptoms, and then we're going to make sure that we are up to date with your preventative care screening. So things like your pap smear, so cervical screening, breast cancer screening, and colorectal cancer screening if you're in your 50s and above. And that we'll talk about in detail next week. So we'll make sure that you're up to date with your screening. We also are going to do some blood work because a lot of symptoms of menopause can mimic other changes to your body as well. So things like hot flashes or period changes we can attribute to thyroid dysfunction. And so we'll do a panel of blood work to check your thyroid function, to do your diabetes screening, cholesterol screening, and just, you know, do a full panel just to see if there's anything else going on that could explain your symptoms. One request that we get quite regularly in office is, hey, doctor, you know, I have all these changes, I have all these symptoms. I want you to check my hormones to see where I am in this journey, where I am in menopause, or if I'm in menopause. So we don't typically check your hormone levels to see if you're in menopause or perimenopause, because the hormone levels, there's such a wide range of normal. And so you could be anywhere within the normal range, and that doesn't tell us or give us any new information. What does give us the information is your symptoms. So any symptoms that you're having gives us more of an indication of where you are in that cycle than the hormone levels. And we don't need to check your hormone levels to determine what kind of treatment we give you. So that's another thing, that hormone levels at this point don't really help us, but your clinical symptoms do. So treatment for perimenopause or menopause can be broken down into non-hormonal treatments and hormonal treatments. So the hormonal treatments we'll discuss in detail a little bit later on, but I just wanted to go through the non-hormonal treatments first. So that is further broken down in things that you can do yourself at home or with the help of other professionals. And there's also prescribed medications that are non-hormonal that can help with your symptoms as well. So some of the non-hormonal management that you can do. So weight gain is sort of part of the natural change in the body as we go through the perimenopause, menopause phase. And so improving your physical activity, improving your diet, and just your overall lifestyle can really, really help with those symptoms. If you're experiencing any pelvic floor dysfunction, vaginal dryness, urinary incontinence, pelvic floor physiotherapy can really, really help with that. So it's a physiotherapist that specializes in strengthening the pelvic floor muscles. And as we get older, if we've had pregnancies, if we've had vaginal deliveries, we know that our pelvic floor muscles become lax and weaker. And so the pelvic floor therapy really, really does help to strengthen and can help with those symptoms. Cognitive behavioral therapy is a type of therapy that can really help with your mood changes. So if you're starting to experience those mood changes we talked about, therapy can really, really help to kind of figure out why those changes are happening and also how can you cope with those changes. So it can give you tips and tools on how you can manage those changes in your day-to-day. We know, as we had last week, that menopause can affect the strength of your bones. So they can make your bones weaker as the estrogen levels do drop. And so one thing that you can do is start taking calcium and vitamin D supplements. So calcium, we do recommend around 800 to 1,000 milligrams a day. And that is a combination of your diet and a supplement. So if you're somebody who does have a lot of calcium in your diet, you may not need to take a supplement, but if you don't, then a supplement can definitely help with the strength of the bones. Vitamin D, so we live in Canada, we don't get a lot of sun, and so most Canadians are low in vitamin D, and so we do recommend taking a vitamin D supplement. About 2,000 units a day can really help with strengthening of the bones as well. So other non-hormonal treatments. So there are over-the-counter natural supplements that can be taken that are marketed for menopause and specific symptoms of menopause as well. The scientific research is limited, so we definitely advise caution before you do start any of these supplements. If you're somebody who is taking medications, you want to make sure that there's no interaction with the medications, and so it's best to talk to your pharmacist who can, see if there's any interaction and can guide you on whether it's safe for you to take. There are antidepressant medications, so venlafaxine or Effexor is another name for it. It can help with mood symptoms, but it is also shown to help with the symptoms of hot flashes as well. So if somebody comes in and they have mood changes and hot flashes, this would be a good first medication to try with them. There is a nerve medication. So gabapentin is a medication that can be used for pain, but it also has also shown to help with hot flashes and mood changes. There's a blood pressure medication. It's not used very often, but it's called clonidine, and that can also help with hot flashes. For vaginal symptoms, there are water-based vaginal treatments that are available over the counter at the pharmacy. So lubrications, there's gels, there's things out there that you can use to see if you can get that moisture back into the vaginal canal. And then there are other medications called selective estrogen receptor modulators. So these are not hormones, but they mimic the estrogen hormone. So what it does, it acts on the estrogen receptor and acts like an estrogen. So it can help with the menopausal symptoms, but it's not a hormone. Okay, so we're going to talk about hormone replacement therapy. There's a lot of controversy around hormone replacement therapy, a lot of stigma around it. There was a study done many years ago by the Women's Health Initiative that didn't put out a lot of, they put out a lot of scary information about hormone replacement therapy. Let's say that it causes breast cancer, that it's unsafe and you shouldn't use it. And so that scared patients. A lot of doctors didn't prescribe it because they were worried that they were gonna make their patients sicker. Since then, there have been many, many studies that show that hormone replacement therapy is safe and effective. And so that's what I'm gonna go through now. So I just wanted to go through some myths and facts about hormone replacement therapy. You may have come across some of these, you may not have, but one of the myths are that hormone replacement therapy causes weight gain. We know that's not true. We know that women have a tendency to gain weight as they get older and enter the midlife, but there's no evidence that the hormone replacement therapy is actually going to make that worse or is responsible for it. Another myth is that hormone replacement therapy causes heart attacks and strokes. So actually studies have shown that women who are age 60 or less or have started hormone replacement therapy between the ages of 50 and 59 or 10 years within starting menopause actually can have a reduced risk of a heart attack and stroke. As you get older, the risk can increase slightly, but it doesn't cause heart attacks and strokes. Another myth is that if you are taking hormone replacement therapy, that you no longer need to have contraception. That's also a myth. If you are still menstruating and you are on hormone replacement therapy for other symptoms of menopause, you still do need contraceptives. So talk to your doctor about that because you can still get pregnant. We talked about this already, that hormone levels need to be checked before starting hormone replacement therapy. We don't need to do that. And I think this is one of the biggest myths out there that many of you have heard, is that hormone replacement therapy causes breast cancer. So in the next slide, I just wanted to show you that the risk that it doesn't cause, hormone replacement therapy doesn't cause breast cancer. But if we look at this table from the UK, at baseline, so a healthy women, so 1,000 healthy women, 23 cases of breast cancer are diagnosed per 1,000 of those healthy women in the UK over the next 5 years. So if you look at the additional risk, so if a woman is overweight or obese, so their BMI is 30 or greater, there's 24 extra cases in women in those cases. So the risk is higher if you are with a BMI of 30 or more. If you look down, so cases in women who are on combined hormone replacement therapy, there is only an additional 4 cases per 1,000 of a risk of getting breast cancer. So the risk is very low compared to if your BMI is 30. And then there are some protective factors as well. So women who are exercising or do at least 2.5 hours of moderate exercise per week, it helps to reduce the risk of breast cancer. And those women who are on estrogen therapy alone, it's protective and you get 4 fewer cases of breast cancer. So overall, we know that hormone replacement therapy is safe, it's effective. We know that hormone replacement therapy can be used safely within 10 years of menopause and for women under the age of 60 who have had the appropriate screening done. The benefits include relief of symptoms such as mood changes, brain fog, hot flashes, insomnia. We know it improves your bone density and help protects the bone density. It's protective of heart disease, and it can help with vaginal dryness and painful intercourse as well. So there are some potential risks of taking hormone replacement therapy. This is the case with any medication that you take. Any medication comes with their risks and benefits. So hormone replacement therapy can slightly increase the risk of stroke and blood clots. So if you take 10,000 people, the studies show that out of the 10,000 people who are on hormone replacement therapy, only 2 people are at risk of getting stroke or blood clot. So the risk is very, very low. If you do take combined hormone replacement therapy, like we saw on the slide before, there may be a slightly increased risk of breast cancer, but again, it's very, very low. If you are taking combined hormone replacement therapy, so estrogen and progesterone, the risk of endometrial cancer is there's no risk. And that's because the progesterone is protective, and we'll talk a bit about that a little later. If you do take hormone replacement therapy over 60, so if you're approaching, if you're in your 60s, there is a slight increased risk of dementia, clots, heart disease, but it's only slight. So many women in their 60s and over 60s can still use hormone replacement therapy very safely, but you're just monitored very, very closely, and obviously the risk and benefit is discussed before we continue into that age group. Okay, so is HRT right for me? So before we say you're a patient in front of us and you want to go on hormone replacement therapy, and before we say yes, you can. We do have to make sure that it is safe for you to go on it. So there are certain contraindications. So these are factors which, if you have them or if you have this condition, that you can't go on hormone replacement therapy. So for example, if you have a personal history of an estrogen-dependent cancer, such as breast cancer, endometrial cancer, or ovarian cancer, we usually don't put patients on hormone replacement therapy. Unexplained vaginal bleeding. So if you have a vaginal bleeding that is different from your menstrual cycle, and we still can't figure out what is the cause of that vaginal bleeding, then we won't put you on hormone replacement therapy until we can figure that out. If you're somebody who has coronary heart disease, so if you've had heart attack, if you've got stents put in, if you have a stroke, or if you have a clot, or you've had a previous history of any of those, then we usually don't. If you have acute liver disease, so if you're basically when we eat, when we take our medications, things, or when we ingest food, everything is metabolized by the liver. So if your liver isn't functioning properly, then the medication isn't metabolized properly, and then you have high levels of hormone in your body. That can be a risk. And so we try to avoid, especially oral hormone replacement therapy, we would try to avoid. If you have migraines with an aura, so an aura is something that you perceive before your migraine comes along. So that can be vision changes, that can be a smell, or a nerve, like you could have like numbness or tingling. Before your migraine happens, then we don't usually give it then. So there is a category. So if patients are at slight risk, so if they have these certain conditions, they may be at a slight risk for any adverse effects with hormone replacement therapy. So for patients who have diabetes, high blood pressure, high triglyceride levels, so if they have those, and they're not well controlled, we may avoid hormone replacement therapy in those patients because their risks of like cardiovascular disease can increase with that. However, if you're a diabetic and your sugars are well controlled, your blood pressure is well controlled, your cholesterol is well controlled, you're on medication, then there should be no problem with that. And we can still give you hormone replacement therapy, but we just have to monitor you closely. Obesity is another one where there is that slight risk. However, if you're actively working towards reducing your weight, then we can give you the hormone replacement therapy. Again, we just have to monitor you closely. Migraines without an aura, if you have malabsorption symptoms where you have trouble absorbing things in your gut, we use with caution, and also gallstones as well. So if you have gallstones, then the estrogen can sometimes increase the number of gallstones, and so we just slightly cautious there as well. And for someone who's recently gone into menopause, they have normal weight, normal blood pressure, they're at low risk for heart disease or a stroke, and a low risk for breast cancer, we go ahead. It's a no-brainer at that point. If they need it, we give it to them. There are side effects of taking hormone replacement therapy. So again, as with any medication you take, there can be side effects. So one of them is vaginal bleeding, and this can occur as most commonly is spotting, but it can be more than that. So it affects different women differently, but it can occur for up to a year after starting hormone replacement therapy. But if it's something that's bothersome, if it's something that's new and different, talk to your doctor. You may need to get some testing done, and that's totally fine. Breast tenderness, bloating, nausea, headaches, they're all common symptoms of starting hormone replacement therapy. And symptoms can be treated by adjusting the dose of hormone replacement therapy. So a lot of the times we can adjust the dose and the symptoms go away. Sometimes we keep you on the same dose and your body just needs time to adjust and the symptoms will go away. But if they don't and they're really bothersome, we take you off of the hormone replacement therapy, and then we can look at other alternatives for you at that point. So the hormone replacement therapy, so there's two different types of hormones that we're looking to replace when we talk about hormone replacement therapy, and that's estrogen and progesterone. And the type of hormone therapy you'll go on, the form of hormone therapy, it all depends on your age, your symptoms, any comorbidities, so your health, and what symptoms you have. So if you have mild symptoms, you may not need to go on hormone replacement therapy. If you have really severe symptoms, hormone replacement therapy may be able to help. And if you're somewhere in between, then we could do either non-hormonal or hormonal. So it all just depends on you and what your symptoms are and what you want to do. So, you may not have heard good things about hormone replacement therapy and you don't want to try it. That's okay. There are other options for you as well. So we just go to your doctor, you have that chat, and then we can decide and see what's best for you. So types of hormone replacement therapy. So I know it says estrogen replacement at the top, but it's actually can apply for progesterone as well. So it can come in oral form, vaginal form. So vaginal, you can get pessaries, rings, creams, and transdermal. So where it gets absorbed through your skin, you can get implants, patches, sprays, and gels. So the oral hormone replacement therapy usually needs to be taken every day. So you can get pills that have estrogen and progesterone combined. You can get estrogen and progesterone on its own as well. And you can also cycle the progesterone. So if you're somebody who wants regular cycles still, you can take estrogen every day and then just add the progesterone in the last 2 weeks of your cycle, and then you'll get a vaginal bleed. Patches. So patches, I find women tend to like them a little bit more because they're more convenient. You just pop them on your body at a muscular part of your body, and you only change them 1 to 2 times a week. So it's not something that you have to remember to take every day. It's very convenient. And a good thing about these patches is it doesn't, the hormone doesn't get metabolized by the liver. So you're not ingesting it. It's not working its way through your digestive system. It's actually just slowly going into the bloodstream from where you attach it. And so any side effects that I mentioned may be significantly less with the patches or the gels or the creams because it's not bypassing the liver. And then you've got vaginal hormone replacement therapy. So you can get an estrogen ring or a pessary, and that's usually changed every 3 months. So again, very, very convenient. So if you have vaginal symptoms, that would be a really great option. And then you also have creams and suppositories. So initially, when you start the cream or suppositories, you take it every day for 2 weeks. And then after that, it's a maintenance dose. So you change it, so you use it twice a week. And that can really help with the symptoms. Sorry, just to go back, when you're using the vaginal hormone replacement therapy, if it's just the vaginal area that you're treating, you can just use estrogen only. So the estrogen, if I just backtrack a little bit. So if a woman has a uterus, so if you have a uterus and you've not had a hysterectomy, if we do decide to give you hormone replacement therapy, we give you estrogen, but we have to also give you that progesterone. So the progesterone helps to protect the endometrial lining in the uterus. If we give you estrogen alone, that lining becomes thicker and thicker, and then you're at risk of getting endometrial cancer. And so that's obviously, we don't want that. So if you have a uterus, if you take estrogen, you must also take progesterone as well. So the progesterone can be in a oral form. You can have it as patches as well, or you can have an IUD put in. So say, for example, you have very heavy periods and you have the Mirena, which is a progesterone IUD. and that's inserted into the endometrial canal, that is your protection for your endometrial lining. So at that point, then you can take estrogen on top of that on its own because you have that progesterone there. When it comes to vaginal treatment, you can just use estrogen alone because that estrogen is just acting locally within the vaginal canal. It's not going to be absorbed into any other part of your body. So it's not going to cause that risk of getting endometrial thickening. So for vaginal treatment, estrogen alone is totally fine to use. A lot of patients ask me, how long do I need to be on hormone replacement therapy? So there's not really a right time to stop. It all depends on your symptoms and how you're feeling. Many women do try to stop approximately 5 years after starting, and that's just because, you know, you've been on it for a really long time. Let's see how you do without some. And sometimes some of the risks, as we said, depending on what age you started, can sometimes slightly increase as you get older. So around 5 years is a really good time to say, okay, let's evaluate your symptoms. Let's see how you're doing. And let's see if, you know, we can come off of this. Do you still need it? Because as we get older, as we go through the menopause journey, some of those menopause symptoms can subside on its own. And so you may no longer need the hormone replacement. So how we can do that is we can gradually lower the dose. So we can say, okay, you're on this dose, let's make it lower and see how you do. And then eventually we stop it. And when you stop it, your symptoms may have gone away and it may be great and you may feel back to normal, or they may not. So if you find that your symptoms have come back or they're worse than they were, then you and your doctor will evaluate sort of how old you are, have any other health issues cropped up, and is it safe for you to go back on it? And if it is, absolutely, you can go back on it. And if it isn't, then there are those non-hormonal treatments that we can use to help with those symptoms. So like I said, we evaluate your risks and benefits, and then we see if you can continue. Okay, so I just prepared 3 case studies, just so you can get an idea of how vastly different every woman will be treated when it comes to hormone replacement therapy. So case 1, so we have a 48-year-old female. She has hot flashes that are affecting her sleep, that affect her during the day at work as well. She comes in, she says, I'm dripping in sweat, and it just comes out of nowhere. She doesn't have any vaginal dryness. Her mood is affected because A, she's not getting enough sleep because these hot flashes are waking her up in the middle of the night. And B, she's just getting these hot flashes and they're debilitating. It's affecting her day to day. And so her mood is really affected. Her periods are regular, but she has noticed that they are getting heavier. And she's generally healthy. So she's healthy. She doesn't take any medications. So what kind of things can we give to her? So she comes in, we make sure we do our preventative health screen. We'll do the blood work. And then we consider both hormonal and non-hormonal options for her. Now, she has friends who are on hormonal treatment and they love it. They say it's a game changer. It really significantly improves their quality of life. And she wants to try it. So she would actually be a great candidate to try hormone replacement therapy. She's got the vasomotor symptoms. She's got the mood changes. So we can look into maybe giving her a combination patch. It's quite convenient. So like we said, she puts it on and changes it once or twice a week. She could consider oral medication for it as well. So you could do oral estrogen progesterone, you could do oral progesterone topical estrogen. So there's lots of combinations there. She also has heavy bleeding. So this patient may benefit from an IUD. The IUD can help slow down her breathing, and then she can get some estrogen therapy on top of that as well. And for her, that IUD would also act as a contraceptive as well. So this patient has a uterus, so we need to make sure that we do give her both estrogen and progesterone treatments. And like I said, she can also try the non-hormonal treatments as well if she wanted. And in regard to her mood changes, she may benefit from cognitive behavioral therapy as she goes through this change. So that's important to consider. Yes, we can treat you with medication, but that therapy can also help you as well. So second patient, so it's a 51-year-old female patient. She has vaginal dryness, painful intercourse. She has burning with urination. She takes blood pressure medications, but generally her blood pressure is very well controlled. She has not had a period for a year, so we know she is fully in menopause, and she doesn't have any other symptoms of menopause. So how can we treat this patient? So again, same thing, we do your preventative health screen, we do the blood work. It's important to make sure we do a physical exam on this patient because vaginal dryness atrophy is something that we can see on physical exam. So that'll help with our treatment as well, knowing that we've seen it and we know that this is what the patient is going through. And because this patient has predominantly vaginal symptoms, we can use any of the vaginal estrogen treatments for her. So estrogen cream, estrogen suppositories, or even the ring. Pelvic floor therapy may actually be very, very beneficial for her as well. And like we mentioned, because if a patient has a uterus, we can still use estrogen-only cream in the vaginal area. It is safe and it's not going to increase her risk of any of the complications at all. And in this patient, non-hormonal treatments can also be beneficial as well. So, either option, it all depends on patient preference. And the last case study, so this is a 50-year-old female. She had a hysterectomy this year for very heavy periods. She has hot flashes, night sweats, mood changes. She's generally healthy, and we know she has no contraindications to hormone replacement therapy. So this woman, same thing. We do the screening, we do the blood work. This patient will benefit from estrogen therapy alone. She doesn't have a uterus. We're not worried about any endometrial thickening or the risk of endometrial cancer. And so this patient can do estrogen therapy alone. It can be in a form of a gel, a patch, it can be oral, whatever the patient's preference. And non-hormonal therapies can also work for this patient as well. Okay, so thank you so much for listening. I just wanted to say that, we're all going to go through this journey. We'll have all a wide variety of symptoms, but don't suffer with those symptoms. If you notice these symptoms, know that there is treatment available for you. Know that if you're worried about the hormones, that's okay. There are non-hormonal treatments, but also know that hormone therapy is safe, and we'll make sure that we screen you, make sure you don't have any contraindications or anything like that before we start you on them. So it is safe. And yeah, just reach out to your doctor and have that discussion with them. Thank you for listening. Does anyone have any questions?
Thank you, Rashida. That was really, really informative. There are actually a couple of questions. So one is, can your GP prescribe it, or do you have to be referred to a specialist? So can your family doctor do it, or do you have to be referred? And the other one, is it addictive, and can it be problematic to come off of it?
Yeah, so your GP can absolutely prescribe it. So I do it all the time because a lot of patients where as a family doctor, we're your first port of call. So you're going to come to us first when you have all these symptoms. And if we were to wait to refer you to a gynecologist in Ontario, the wait times are really, really bad. And so you'll be waiting sometimes months and months to get in to see a gynecologist. So we are more, we can prescribe, or we can even start the process while you're waiting to see a gynecologist. But yeah, we are absolutely able to prescribe HRT for you and monitor you throughout your treatment as well. And sorry, what was the second question? Is it addictive?
Yeah.
Definitely no, it's not addictive at all. And It's not problematic when you come off of it. So like I said, we can always do a slow taper. So we can, reduce the dose slowly, or some women just come off of it altogether. So like I said, some women's symptoms do come back and they may need to go back on it. That doesn't mean that they're addicted to it. It just means that the menopausal symptoms are just being really prolonged and they're not going away with time. And so you may just need an extra little while with the menopause, but that doesn't mean you're addicted to them at all.
Awesome, thank you. While we're waiting for more questions, I just wanted to just reiterate that our next talk is actually not next week because it's Family Day on Monday. So it'll be the week after. It'll be on the 24th of Feb, or 26th Shaban, the same time, so 8:30, and that one's on cancer screening. It's actually applicable to anyone over the age of 25, so 25 to 74. So if you fall in that age group, please do attend. Okay, we will send out the link anyway, but I just thought I'd um, say that. Okay, so yeah, I think Rashida's going to hang around for longer. So if you have any questions, feel free to either type them or just ask them out.
Yeah, I'm sorry, I'm just gonna share my screen again. We would appreciate any feedback. So if you want to scan this QR code or go onto the website, we do have a feedback form. So any feedback, anything you'd like to see, anything we can do better, please do give us your feedback because we would like to make these sessions better for you. So yeah, please fill those out. And you'll see when you go onto the form, the different sessions that we're going to be doing. So just click on the session that you want to evaluate and fill out the form. Thank you.
Have you shared your screen?
I did.
I can't see
Oh, you
it.
can't see it? Okay.
No.
You know what? I'm gonna put I'll put it in the chat if it lets me. So I've just put the QR code in the chat.
Yeah.
Actually, is that sharing it now?
Give it a second. Yeah, it is.
Yeah. Okay. There you go.